This is a patient with a retinal detachment and significant PVR. It was a chronic retinal detachment, and she presented very late. So what we can see, we do a cataract surgery in this case. I don't always do a combined, but in some cases I like to, especially when I know I'm going to be addressing PVR. So we do the phaco. She's got a round hole, and you can see that there seems to be a subretinal band that I've highlighted and zoomed in on. And I'm going to address that later. I want to check the mobility of the retina. So I do my peripheral vitrectomy first, and that allows me to kind of identify how far and how extensive the detachment is. In this case, she's got a total retinal detachment, so there's no areas of attached retina. And I stain with triamcinolone, and I'm going to use that later to do an indented shave. I know she's got a PVD. I checked for that at the start. What I'm doing here now is applying diathermy to the edges of the round hole that she's got and the break, and that just shows very nicely the subretinal adhesion that we've got. And I use the forceps to engage it and try and pull it out. Now, often they bleed a little bit, so diathermy is useful. You can't always prevent all of the blood, but I managed to tease it out using the light pipe as a counter traction. When I check underneath, I'm satisfied now. There's no subretinal membranes. I next perform indented shave, 360 degrees. I don't typically do this step with retinal detachment surgery. However, I think in this case it's useful. There's a small micro hole that I see, so I just cryo it under fluid. I'm using the flex loop now. There's an area of lattice with really strongly adherent vitreous on it, and I really want to remove this given the nature of how extensive a retinal detachment is. So I'm going to use some heavy liquid now. My plan is to peel some ILM because I can see that she has some posterior PVR. So I can see that temporal to macula is some posterior PVR, and my plan is to peel that under heavy liquid. Often if I have a retinal detachment with a macular hole, I won't necessarily use heavy liquid, but in this case, I think it does provide a nice counter traction and just allows me to also see what's happening with the retinal status and get an idea of how much flexibility I get back. So I try and avoid using heavy liquid where I can, but in this case I felt I needed to. The goal is to try and remove as much ILM without causing any trauma or iatrogenic trauma. It can be difficult because obviously the flap is not clearly evident. I think it can take some time, but we're getting a nice peel, and I'm peeling around the areas that I can see there's significant ERM or significant risk of posterior PVR developing further down the line, and I'm managing to peel quite nicely good areas of the ILM, and it's definitely helping the retina relax a little bit and giving me a bit more retinal redundancy. I'm trying to avoid at all costs a retinectomy if I can. The next step is I'm going to do 360 laser. I've made a superior retinotomy where the previous lattice was, and that's just because I was unable to remove the gel around that lattice. I trimmed it all the way down, and often I would just islandize that lattice. However, in this case, I felt that removing that small area was not an issue, especially as it was so close to the main break. Now, this is an interesting thing that occurs when I go to air. You can see that the view is horrific, and I come back to the AC and I can see there's air in the AC. So I remove the air and replace it with BSS, just a tip, and you can get a much nicer view. And this is the view that you're used to when you're under air. So I can just perform the fluid air exchange and try and drain the retina. I want it completely flat, or as flat as possible. And I've got heavy liquid in, but I'm going to the break and then back to the heavy liquid and then back to the break. And I do that maneuver multiple times until I'm satisfied that there's no further subretinal fluid and also no heavy liquid left in the eye. Once I'm satisfied with that maneuver and I'm happy that the eye is completely flat and filled with air, that gives me an idea of how the retina is going to look, and I'm happy with the retinal architecture. I then perform some more laser spoking it because again she has high risk of PVR, so I spoke off areas of the retina that if she does develop an annular detachment, it'll be localized, and then I fill with silicone 1300 and suture the remaining ports, and that concludes the end of the case. It's a long case, this one. It takes about 90 minutes. Thank you for your attention.